I could do it without.
For Zoom, yes, for Zoom. Good morning. All right, I think the microphone is on. I'm Hillary Lum. Welcome to Geriatric's Grand Rounds to those of you in the room and on Zoom. We are very excited to have Dr. Enrique Soto with us today. Before that, a few announcements. Happy Halloween, happy Samhain, there are many other things around right now. And next Thursday, 1 week from today, we will still be here for Grand Rounds. So come next Thursday, we have Dr. Marie-Therese Connolly, MT Connolly, will be speaking as part of the Elder Justice Summit, which is on Wednesday, but then specifically in Grand Rounds Thursday morning. Our next journal club is on Zoom, which is November 14th. And we will also ask you to complete the evaluation so that we can give feedback about future Grand Rounds as well as this Grand Rounds. So by way of speaker introduction, we're very excited to have Dr. Enrique Soto join us for Grand Rounds. He is an associate professor of medical oncology here at University of Colorado and associate director of global oncology at the University of Colorado Cancer Center. He's a geriatric oncologist and trained in medical oncology at National Institute of Medical Science in Mexico City and at the City of Hope National Medical Center in Los Angeles. He has a PhD in medical science from the National Autonomous University of Mexico. In Mexico, Dr. Soto founded the Cancer Care in Older Adult Clinic, the first multidisciplinary geriatric oncology clinic in Spanish-speaking Latin America. He is a past recipient of the American Society of Clinical Oncology Young Investigator Award, a Career Development Award, and Long-Term International Fellowship, as well as a former member of the ASCO Board of Directors, an associate editor of the Journal of Geriatric Oncology, and editor-in-chief of eCancer. He recently received the 2024 Paul Calabrese Lifetime Achievement Award from the International Society of Geriatric Oncology. So we're really excited to have him speak with us today.
Thank you so much for the introduction, and thank you so much for having me here. I'm a recent move to the university. I moved here in May, and it has been amazing to get to know so many people. And it's an honor to be invited to talk with you. When I was working in Mexico, I was actually working not in the Department of Oncology, but in the Department of Geriatrics. And I really miss working with geriatricians, nicest people in medicine. So today I'm gonna talk about how to tailor geriatric oncology care and focusing on models and implementation across diverse healthcare settings. Most of the talks I give are for oncologists, so gladly I don't have to go over what the geriatric assessment is and all of those things that I normally do. This is my Twitter handle in case you want to connect later. I have no conflicts of interest to disclose. And the learning objectives for today are to analyze the key challenges faced by older adults with cancer in resource-limited settings, considering that we all work in resource-limited settings in a way, including the barriers for accessing specialized care, try to identify effective strategies and models for integrated geriatric oncology principles across diverse healthcare systems, local context and resource availability, and finally, to try to figure out some practical approaches for developing collaborations, training, and partnerships to enhance and improve outcomes for older patients with cancer. It's no secret that the world is getting older. This is a map of the year 2015. With countries with the higher proportion of older patients defined as 65 and above in red. And of course, most of the concentration or proportion of older adults is located in the US, Canada, and Western Europe. However, if we fast forward to 2050, most of the world will be aging, and most of this aging will occur in low and middle income countries. And as you know, in low and middle income countries, healthcare systems are less prepared to deal with chronic diseases and with other diseases associated with aging, since most of the healthcare system in those settings are designed to tackle infectious diseases. And so this will, of course, be a challenge for healthcare system in particular, And for cancer, specifically, this will be a great challenge. This aging is taking place, it's taking place all across the world, but the regions of the world that will age more rapidly are particularly Asia, Latin America. In Latin America, in particular, in Mexico, for example, our Mexican baby boomers, so to speak, were born in the 70s when we were making a lot of oil. And so that population is gonna be turning 65 very soon. And even today, almost 400 million older adults are living in developing countries. So although the proportion of older adults in those countries is smaller due to the sheer magnitude of the population, the absolute number of older adults is higher in the developing world than in high-income countries. And how will this impact cancer? This is statistics from the Global Cancer Database, the number of yearly diagnosed cancers in the world in 2020 and 2024 in people 0 to 64, and then in people over 65 years. And as you can see, in people over 65 years, the number of cancer cases per year will double. And by the year 2040, most cancer cases, or more than 2/3 of cancer cases, will occur in older adults. So this definitely shows that cancer is a disease of aging. And age and geography greatly influence the outcomes of older adults with cancer. We published this now 8 years ago, and this is the incidence to mortality ratio. Thus, the number of people who die related to the number of people that are diagnosed with cancer, which is an imperfect measure of outcomes. And as you can see, depending on where you live, so by continent and also by age, your incidence to mortality ratio is greatly influenced. So for example, someone over 75 diagnosed with cancer in Africa has a probability of almost 100% of dying from cancer. And this is not true in other places. So access and age greatly influence outcomes. And what this shows is that we need to improve the way in which we treat older people with cancer worldwide, and that it is necessary to provide geriatric-centered care for patients all around the world. So geriatric oncology is not a luxury. I think it is a necessity. It allows us to better understand our patients, to provide high-quality service, and for oncologists, it allows us to simplify the complex. Sometimes when facing an older patient, as oncologists, we just don't know what to do. And that is because we are not trained on what to ask or what to do when we find things that are abnormal. However, of course, there are several barriers for geriatric oncology care, including patient selection, which patients to send to a geriatric oncology consultation, tool selection, which as geriatricians, you may find less of a problem, but oncologists get stuck on which tool to use and talk about it so much that it's like the tools are already there, but this is something that happens. And of course, the availability of interventions. If we find something and we want to act upon it, do we even have the resources to do those things? Because you all know that assessing something without acting upon it means nothing. So what are the barriers that older adults with cancer face? Ageism from personnel and for patients themselves. This is extremely common in cancer care. Patients and relatives thinking that care is not even worth it. Low inclusion into clinical trials of novel therapies. The proportion of older patients included in clinical trials is dismal. In lung cancer, for example, in which 70% of patients are over 70, only 7% of clinical trial participants are over 70. There is a reluctance to provide patients with more aggressive therapy even when they are fit. And of course, a lack of adequate and tailored supportive care services that are designed to treat older patients. The lack of geriatric expertise is a problem worldwide. This is from a paper we published some years ago looking at the number of geriatricians in countries in Latin America. And I know that in the US, you have a geriatric shortage and that a lot of geriatric positions are left unoccupied. But the problem is even worse if you look at other places of the world. In Mexico, in 2018, there were only 400 geriatricians in the entire country. Bear in mind, it's a country of 140 million people. And now it's not that much better. It's like 520. And this is happening all around the world. There is a lack of geriatric expertise all around the world. And I think we have to start thinking of out-of-the-box approaches to face this shortage. And of course, this leads us to answer, how can we include geriatric principles into cancer care across all settings with this limited human resource? And in 2011, the International Society of Geriatric Oncology tried to provide some guidance as to how to answer that question by publishing the 10 Priorities Initiative. And this was 10 things that at that moment were considered as the most important things to advance the field of geriatric oncology. And today I'm going to talk about 3 of these. One, the development of geriatric assessment tools, which has been a thing that has limited the field, I believe, in many cases. The development of models of care, which is something that I really think is the most important issue. And finally, improving access to care, which in many cases is beyond what we can do as providers. So for me, the main issue about geriatric assessment tools is not that they're not available, that we have to invent one. I was actually at a conference with one of the founders of the Memorial Sloan Kettering Geriatric Oncology Group. She was a nurse, and she said, if I see you invent one more geriatric assessment tool, I'm going to come back from the death and pull your feet. However, one size may not fit all, and some tools may be difficult to understand or to complete depending on educational background and social circumstances. So in City of Hope, they designed this Cancer and Aging Research Group self-administered geriatric assessment, and they tested it in English-speaking patients in Southern California. And what they found was that 90% of patients were able to complete the assessment, and that on average, they completed it in 18 minutes. And then when I was there doing my training in 2017, we tried to do the same assessment, translated and gave it to patients that spoke Spanish. And only 61% of the patients were able to complete it, and it took them 30 minutes. And this, of course, is not because people who speak Spanish cannot understand questions, but it's because Spanish-speaking patients in the US had an average schooling, or the patients, at least the patients we asked to complete the assessment, had an average schooling of 6th grade, compared with college educations for other patients. And 6th grade, 5th grade is the average schooling of older people living in Mexico today. This will change in 30 years, right? But the people that are migrating to the US who are older adults have elementary school education. And of course, you cannot expect them to answer the same survey that someone who has a college education should do. And so actually, with Dr. Andrea Pérez de Hacha, one of our geriatricians in Mexico, we developed a brief self-administered geriatric assessment, trying to use the simplest validated tools in Spanish. And in a population that was 40% elementary school, they took 18 minutes to complete, 70% completed it on their own, and the rest were able to complete it with help from a relative. So I think that although the tools are there, we need to be sure that we are tailoring to the population that we are seeing. And this is an example I really like. If you ask a patient living in a city like this, in Barcelona or in Milan or in Denver, if they can walk a city block, that makes sense. But if you ask it to someone who lives in a place like this, what the hell does a block even mean, right? So we do need to make sure that we tailor assessments and delivery of clinical care to the populations that we're seeing, particularly in places like this, when we see people from all over the world. Just the other day in clinic, I did geriatric assessments on someone from Ethiopia, South Africa, Mexico, and the US in a matter of 2 hours. So of course, we cannot ask exactly the same questions to everyone. And there are a lot of contrast and disparities in access. This is from a paper we published a few years ago looking at geriatric oncology clinics in the US. The geriatric oncology clinics are those that have, and in Canada, are those that have a blue star. And as you can see, most of the clinics are located in the East Coast, and this has not changed a lot in the last 8 years. So most of the country and most of the world has no access to geriatric oncology care. And if we look at other places like Latin America, it's even worse, right? Only geriatric oncology clinics are located in Mexico and in Brazil. And the truth is that most oncologists in the world are working alone without any input from people with geriatric expertise. And we have to figure out models of care to help all patients get geriatric expertise. And broadly speaking, there are 3 models of geriatric oncology care that have been implemented. The first one is the integrated geriatric oncology clinic. In this type of clinic, someone who is dually trained in oncology and geriatrics assesses the patients and implements interventions with a specialized team. This allows for centralization of geriatric expertise. It facilitates integration because it's just one person, right? It may reduce the burden for other oncologists, and it's the fastest model to identify patients and to implement treatment modifications because the same person is doing everything, right? I make the recommendations to myself. However, the problem is that people that are dually trained are seldom available. There is a limited number of patients that can be evaluated using this model, and it requires highly specialized personnel, which may not exist, not even in developing countries, but also in various places in highly developed countries like the US. The second model, which is perhaps one of the most popular, is a consultative geriatric oncology model in which the patient remains under supervision from the treating oncologist with co-management with a geriatrician. This can reach most older adults with cancer. It favors interaction between team members, and multidisciplinary care with geriatric expertise can be provided. There are, of course, challenges, particularly the logistical and practical challenges. Patient selection criteria, referral criteria, fast referrals are a challenge, and this highly depends on communication. So a lack of communication or even a lack of goodwill between oncologists and geriatricians can severely hamper the functioning of this model, and it, of course, depends on the availability of local resources and staff. And finally, the other model is the oncologist working with referrals to geriatrics or to other personnel. The patient remains under supervision from the oncologists, and interventions are done with referrals to other doctors within or other professionals within the site in which the oncologist is working, or even within the community. This is a problem because although it may be good for places that do not have access to a geriatrician, it is more time consuming to the oncologist, and there's less perceived value for oncologists in many cases. So can this be done across all settings? Yes, but access to care is still an issue. One size, of course, does not fit all because resources, talking about personal space and, of course, money, are different everywhere. And some things that may seem absurd become big challenges. For example, in Mexico, when we were trying to set up the clinic, just having the administrative personnel allow us to put a mark on the floor to do a timed up and go took us months, right? So these are things that seem stupid, but that make it difficult to implement these things. However, no matter how little resources you have, there is always something to do. And we need to figure out how we can optimize access to care with what we have. We tried to do, a couple of years ago, some recommendations from the Young International Society of Geriatric Oncology group, which always sounds funny, trying to figure out what type of model would be best depending on the type of center that you have, trying to do some resource stratification. I don't know if you're familiar with this concept, but this is a concept that the WHO started and that has been done in a lot of tumors, in which you try to resource stratify depending on the availability of resources and the effectiveness of interventions in improving the most important outcomes, such as survival, quality of life, etc. And so for academic centers, we thought all older patients could receive a geriatric assessment, and geriatric assessment interventions could be implemented. In third-level hospitals, screening tools that are designed to identify those patients who are likely to have deficits upon a full geriatric assessment could be implemented with interventions for selected patients. And finally, in general hospitals or community clinics where geriatric expertise is not available, at least using a screening tool with referrals to other specialists in cases where deficits are identified. And we are actually working now on an American Society of Clinical Oncology Geriatric Oncology Resource Stratified Guideline, which I hope will be coming out in early 2025. And so what did we do in Mexico? We created the Cancer Care in the Older Adult Clinic. That's the first geriatric oncology clinic. And this was done in the geriatrics department because the oncology department didn't have as much enthusiasm for creating it, at least at the beginning. And this is Ana Patricia Navarrete, geriatrician that worked with me, Yvonne Reyes, a nutritionist, and Jesus Ruiz, physical therapist. We were the core members of the clinic. And the idea of the clinic was to have a single multidisciplinary visit in which patients saw an oncologist, a geriatrician, a nutritionist, and a physical therapist, and in which we could refer them to palliative care or social work with a geriatric component. The idea was to do all of this in a single multidisciplinary meeting and then to give recommendations to the treating oncologist, but not to treat the patients ourselves, right? Because that would be impossible. So this is the model that we did. We did an initial assessment with a tool called the G8, which asks 8 questions that are derived from the M&A, an SPPB, and a Minicog. If all of these were normal, the patient was considered fit, and we did not accept the patient into the clinic. No further assessment was required, and the oncologists were free to do whatever they wanted, so to speak. And if any of these was abnormal, patient was potentially vulnerable or frail, and we did a full geriatric assessment and interventions. And our referrals came mostly from surgery, in fact, and neurology, and then from medical oncology, and that took a while to increase. And starting in 2018, we started the clinic in 2016, the initial screening was done by the oncology fellows. So we actually trained the oncology fellows in doing the screening. At the beginning, we had a geriatric screening clinic in which we just did screening, and then we closed that up and just teach the fellows how to do it. And that was one of our greatest achievements, in fact. And we followed FASCO geriatric oncology guidelines regarding the types of assessments and interventions that were needed. So we assessed the domains that you are very, very familiar with: functional status, nutrition, psychological assessments, cognition. And of course, we had the advantage of having access to all of these things since we were a third-level hospital, right? And 2 of the things that we usually do in geriatric oncology is an assessment of life expectancy, or more appropriately, of all-cause mortality risk at 10, 14 years using calculators. And I'm sure you're all familiar with e-prognosis. So we use those tools, and calculation of treatment toxicity using geriatric oncology-specific tools in order to recommend treatment adjustments or whether to give chemotherapy or no, and answer that very important question: is this patient going to die of cancer or with cancer, right? Which is very important for when to give treatment. And we actually assessed the impact of the clinic on cancer treatments. Dr. Verduzco, an oncology fellow, now an oncology attendant, published this in JACS in 2019. And we looked at our first 173 patients with a median age of 79. And what we wanted to see was whether there was any concordance between our recommendations and what oncologists finally did, the influence of the type of recommendation, and the influence of communication. And we used a proxy for communication, which was whether the oncologist mentioned our assessment and our recommendation in their clinic notes. So we did not ask them specifically, we looked at their notes. And so what we found was that when in the clinic we recommended giving patients a standard treatment, the agreement was 81%. When we recommended supportive care alone, it was 89%. Modified treatments, so like reducing dose or omitting one chemotherapy component or one component of treatment, 84%. And overall agreement was significantly higher when recommendations were mentioned. So when the oncologist mentioned the recommendation in the note, it was more likely that they would do what we requested. And of course, it is difficult to know if they just did this to justify that they were making the choice themselves. I said, well, these guys agree with me, or if they actually took this into account. But time showed us that they were actually listening to us. Well, not all of the oncologists, and we'll talk about that a little bit. And this is the evolution of the clinic. I started working there in 2015. We were seeing 4 patients per week. Because, you know, with geriatric assessments and all of these things take a long time. So we had our screening clinic and our first research grant. In 2017, we started training some geriatricians. We started a geriatric hematology clinic, a colon cancer clinic. We were seeing 18 patients per week. I started a collaboration with palliative care in which we had a palliative care specialist right there at the clinic to see patients. In 2018, we started having an oncology fellow rotation into our clinic. So all oncology fellows had to come to see patients with us. We started having participation in the national meeting, and now there's a geriatric oncology module in the national clinic, and we recruited a gerontologist. I'm not sure how familiar you are with this, but it is a 3-year career that in Mexico, you can do it out of high school. It's kind of a technical career, and they train for 3 years in doing assessments and some basic interventions. So this I consider to be a very, very good resource in low and middle income countries. So this gerontologist, who is amazing, and I hope to bring here eventually, she did all of the assessments. And then in 2020 to 2023, we increased to 38 to 40 patients per week, started having international visiting fellows. And one of the nicest things is that last year we started the first geriatric oncology fellowship in Mexico to train oncologists in geriatric oncology. So these things take a long time. So 10 years to increase to 40 patients per week may seem like a long time, but if you see most geriatric oncology clinics in the world, this has been the revolution. So what is the added value of this? And I know I don't need to convince you of this, but identifying patients at increased risk of toxicity and avoid or mitigate it, decrease the time it takes to provide multidisciplinary care for highly complex patients, and try to get all referrals at the same place, train residents and medical students, and it is good for institutional marketing. It actually did a lot of good for our institution. There are, of course, barriers. There is a lack of recognition from other physicians. They have no faith in geriatric oncology. And there are some oncologists that you can never convince, and that's fine, doesn't matter. Yeah, there are some people that you will never convince, right? But you have to just work with the ones that are okay. And the solution, of course, is to provide evidence, communicate, and always be there. We strived to always be at tumor boards, to always have someone with geriatric expertise at the tumor boards, so that that voice could be heard. And if you hear that enough, you'll eventually start to think about it. The lack of personnel, of course, few supportive personnel and lack of specialists. And of course, our solution was, again, to educate the entire staff and geriatricize the oncologists. And I don't mean to be ageist, but mostly the younger ones that are easier to change their mind. Of course, a lack of clarity regarding reasons for referral is a big problem. Criteria have to be very clear. And we actually created a lot of written material about the clinic and gave a lot of lectures to oncologists and to surgeons and neurologists, etc. And finally, catering to the oncologist need is very important. We had the advantage that I was an infiltrated, I was a mole, right? I was an oncologist working with the geriatrician. So I had access to the oncology world, and I spoke the same language, right? And the risk is becoming a usual geriatrics clinic, right? That the oncologists start sending patients that have AFib or something like that. And that's not what this is supposed to be for. And we also don't want to duplicate work with the oncologist. So creating pathways after patients finish their treatment so that the geriatric oncologist is no longer seeing these patients in survival, etc. And we actually created a survivorship clinic, which later we had to shut down because we lost that geriatrician, but that was a potential solution for that. However, and this is the final part of the talk, the question that comes all the time is, how does this impact cancer outcomes, right? Because we all know that geriatric interventions are very important for a lot of geriatric outcomes, right? But if you say that to an oncologist, they'll say, so what? I want patients to live longer, to get cured, to not have toxicity, etc. So up until 2020, there was very little evidence that this actually impacted cancer-specific outcomes. However, starting in 2020, a series of randomized clinical trials have been published that have shown that this can actually impact cancer outcomes. And I'm going to talk about how these trials are adapted to the types of model that we found. So remember that the first model we talked about is the geriatric oncology unit in academic cancer centers with a multidisciplinary team. And for that, there is a trial in which I had the honor to participate at City of Hope, which is the GAIN trial. This was published in JAMA Oncology 3 years ago. And in this trial, we included 600 older adults, 65 and above, with solid tumors at any stage, getting any new chemotherapy. And these patients all of them, it didn't matter what their geriatric assessment was, right? And they were randomized in a 2-to-1 fashion to a geriatric intervention or to standard of care. And the geriatric intervention included performing a geriatric assessment, and then, depending on the deficits identified, to implement a series of predetermined interventions. And here you can see an example, pretty standard things like exercise prescription, gait strengthening, and some very sophisticated Southern California stuff like Reiki and things like that, referrals to chaplaincy, etc. But as you can see, these were complex interventions done by a team in a single center, right? So a unit that is very geriatric focused. And what we found in this trial was that in the standard of care arm, 60% of patients had grade 3 to 5 toxicity. And if you don't know what this means, grade 3 toxicity is the one that impairs your activities of daily living. Grade 4 gets you in the hospital. Grade 5, you're dead. And we were able to reduce this by 10% using geriatric interventions with a dedicated team. And so this was significant for this. And we found no difference in secondary outcomes such as hospital admission, CR visits, or overall survival. And the first two, I expected it because of the way healthcare systems work. And the second one, a no decrease in survival, I think that's okay. I don't think our goal is to increase survival, right? But if we keep the same survival in patients with less toxicity, that for me is a big success. The second trial, which used a geriatric consultation team, which again, as we remember, can be done in large hospitals where you have geriatricians, but you may not have a cancer-specific team. So you may have all these ancillary providers that can give interventions, but are not necessarily geriatric oncology specific. It's a trial that was conducted in Australia and published in the Lancet Healthy Longevity. And this trial is called Integrate. And this included 154 older adults over 70 from 3 Australian institutions. They had solid tumors or lymphoma, mostly lung cancer, and they were getting any systemic treatment. And they were randomized to standard of care or integrated care. And integrated care meant meeting with a geriatrician 3 times during treatment. That's what integrated care meant. And the geriatrician implemented interventions. And what they found was that patients in the integrated oncogeriatric care, this is a measure of quality of life, an older adult specific measure of quality of life, were able to maintain their quality of life without any decline during the course of treatment. And another very interesting thing that they found was a significant reduction in hospitalizations and in the use of the emergency department. And again, I believe that is because the Australian system is slightly different. And since it's a public universal system, it's less likely for patients to have to use the emergency department to get care. They have better access to other things, right? But still showing less resource utilization and better and maintenance of quality of life. And finally, in places where geriatric expertise is unavailable, such as community sites or smaller hospitals and where there is no multidisciplinary team, Dr. Mohile and colleagues from Rochester published the GAP70 trial in the Lancet, and this included 700 older adults over 70, and they were randomized in a cluster randomized fashion, so by community sites in an N-Corp collaborative, to getting a geriatric assessment and then getting these recommendations sent to the oncologist, or just getting treated by the oncologist without looking at the geriatric assessment. And importantly, all of these patients had at least one geriatric syndrome or deficit, and all of the patients had metastatic disease. So in contrast with the other trials, this only included patients with metastatic disease. And what they found was a reduction of 20% in grade 3 to 5 toxicity, and this was both due to non-hematological and hematological toxicity. So slightly higher than what we found in the GATE trial, and I think that has to do with the population that was studied. And what they found was that actually the geriatric assessment intervention group was more likely to receive a reduced dose intensity of chemotherapy and had less dose modifications at 3 months. So the oncologists actually, after seeing the geriatric assessment, without even having to interact with the geriatrician, they dose reduced or made some changes in the treatment. And importantly, that dose reduction did not lead to a worse survival. So even though the oncologist decided to give less treatment, that did not translate into a worse survival. And I think that's extremely important, because if we're going to ask people to give less treatment, we also have to reassure them that their patients are not going to die more, because for oncologists, that's what we're trying to do, right? We want response, we want longer survival, and we don't care as much about the other things, or at least most oncologists don't, right? And that's something that is starting to change, and I believe will change more in the future. So in summary, for geriatric oncology units, we have evidence from the GAIN trial showing decreased toxicity. For geriatric consultation teams, we have evidence from Integrate showing improved quality of life. And for places where geriatric expertise is unavailable, we have evidence from the GAP70 trial regarding decreased toxicity. So how do we move forward? In 2022, we published these priorities for the global advancement of care for older adults on an update of the 2011 recommendations that I spoke about at the beginning of the talk. And we decided to divide priorities into 4: healthcare systems, training, clinical care, and research. And I encourage all of you to think about how your work or the work that you are doing can adapt to these things in cancer, right? So for healthcare systems, including geriatric assessment into national and regional plans and guidelines in order to create age-friendly healthcare systems. Most cancer control plans in the world have no mention of older adults. All of them have mentions of adolescents and young children, which make up like 3% of the cancer population, and none mention older adults, well, almost none. We need to include geriatric competences in the fellowship curricula and train community healthcare workers, which are a super important part of care worldwide and in the community, and create centers of excellence in geriatric oncology. And I want to come back in a little bit to think how we can become one. In clinical care, disseminating the tools that are there in various languages and for various populations, and promoting team building. Getting oncologists and geriatricians together at the same table makes a big difference. Like when geriatricians and oncologists meet each other, start talking, wonderful things happen. And finally, international collaborative projects and fostering funding for cancer and aging research. And so I want to go back to the centers of excellence in geriatric oncology, and I want to think about our institution and think about what could be the best model to implement with what we have. I have my own thoughts, but I would love to hear what you have to say. So should we go for a geriatric oncology clinic with a centralized clinic with dedicated personnel that's interdisciplinary, a place of its own that gets referral from across the cancer center? Should we go for a geriatrician-led consultative model in which perhaps we embed geriatrician in disease-specific groups, and we have geriatricians that assess patients and participate in multidisciplinary tumor clinics and co-manage patients with the oncologists with referrals directed by the geriatrician? So sort of a hub and spoke model in which geriatricians all report to the same place but see patients with various tumors. Or finally, an oncologist-led model, right, in which oncologists screen patients automatically through the EHR or with questionnaires in the clinic. Geriatric assessment is performed by generalist geriatric specialists, so patients get referred, and then recommendations are fed back to the oncologist, and the oncologist decides. And so, can you scan that QR code? I want to see what you think. And also, the people in Zoom, you can just scan the QR code, and if I did it correctly, it should take you to a very simple multiple choice question. Yeah, is it working? Okay. And so I did this correctly as well. Oh, yeah, of course. So, yeah, and actually, this is one of the reasons why I was brought here. The Cancer Center, in its annual review, one of the things that the annual review said is that the Cancer Center was not enrolling enough older patients in clinical trials, and that we are not having a good care for older patients with cancer. And so I bet you all know Liz Kessler. She has done excellent work in implementing geriatric oncology. And my task here is to help her and help all of us build the correct type of care for older patients with cancer. It's a priority for the Cancer Center. And so I think it's a great time to start thinking about this and how we can work together, particularly since we have such a strong geriatrics group here, right? So it's almost a tie. Okay. Yeah. So, so of course, and now that I'm finished, I think we can have a conversation about this, about how I believe this could work, what has been done in other institutions. Most people go for the geriatric oncology clinic, right? Because that creates a lot of enthusiasm and you can do a lot of work. But yeah, amazing. Perfect. We'll come back. We'll come back. Yeah. Great. Yeah, I thought something like that would happen. And so can geriatric oncology be implemented everywhere? Yes, it is extremely necessary, and we have highly motivated people. There are many models of care that already exist and that are adaptable. There are great opportunities to interact with other disciplines. We do have a lot of providers that are excellent for this, that do physical therapy, nutrition, etc. There are opportunities to generate innovation and improve medical care. This is a field that is growing, and geriatric principles can and should be included in the decision-making process for all older adults with cancer. We need more research, of course. I need to think about more about the effect on oncological outcomes, quality of life, function, cognition. We need to develop cost-effectiveness models, right, and business models for this. Inclusion of patient-reported outcomes, strategies to optimize success. How can we use our community sites? How can we work with telemedicine to do many of these interventions so that we make the best use of our time and resources, and many more, like as many as you can think of. And I bet that many of the things you're doing could be adapted or implemented in cancer care. And I would love to hear about that. And finally, of course, what we have to do is meld these two beautiful disciplines into geriatric oncology and work together to improve the care of this highly vulnerable population that really needs our help. So thank you very much. A pleasure to talk with you, and I'm really looking forward to your questions and discussion. Oh, the geriatric oncology clinic is winning.
Excellent talk. We have people on Zoom who, Jessica, if you see that people are chatting in, we'll give them the mic, but I'll start with questions in the room. Sarah.
What were you hoping the survey said?
Oh,
The
no,
last made me think
I
it was
was
different
actually
than
not hoping for anything. I really wanted to see what you guys thought about this, right? And particularly since we have the leadership of the geriatric department here, I think this is a very good conversation starter, right? How can we actually do this and implement this? I mean, one thing that our cancer center has that is very strong and distinguishes the cancer center is, I don't know if you are aware of these MDT things, multidisciplinary tumor boards. And so every time a new patient comes into the cancer center, they are seen in a single multidisciplinary visit by multiple specialists and discussed at a tumor board. And so in GU, in genitourinary malignancies, they have tried to do geriatric assessment and discuss that at the tumor board. And I do believe that that is a good spot to integrate the geriatrician into the teams, because our center is very disease-oriented. Other centers are a little bit more fluid, but here it's very, very separate, right? GU has its clinic, GI has its clinic, breast has its clinic, and we don't talk to each other ever. I've never seen someone who doesn't work in breast since I've been here. Yeah, like we don't interact with other oncologists, so it's more difficult in that sense. But yeah, I think that both models you can actually implement both. In Mexico, we had both. We had the geriatric consultative clinic, and then I had my own clinic in which I saw colorectal and breast in over 70, right? And in that one, I did everything, right? I didn't refer. I referred, but not to geriatrics.
Thank you so much for a great presentation. One thing I'm thinking about, I'm a palliative care doctor as well as geriatrician, and I work in the cancer center in the palliative care clinic, and I'm thinking about what your thoughts are on values-based goals of care in addition to geriatric assessment and how that might influence a geriatric oncology clinic.
Oh, well, it influences enormously, right? I think this is a super important part, and we could do an entire presentation on that. But of course, patient preferences, trade-offs, value-based goals of care influences how we decide treatment, or it should influence how we decide our treatment. Unfortunately, in most cases, it doesn't, right? Still, traditional measures such as progression-free survival and all of those things that we love in oncology are the main thing guiding treatment. But I do think that integrating this into cancer care is very important. And in palliative care, actually, geriatric oncology has a lot of similarities with palliative care, in which there is a value that is shown to be there, And yet, most patients are not getting those palliative care consultations, those palliative care referrals. And in many cases, it's because the model makes it difficult for patients to access. There is a long waiting list, things like that. No? So I think there is a lot of similarities and things that we can learn from palliative care when implementing our clinics, and learning about the experience that you've had with implementing palliative care here and how you've made it work would be very important for geriatric oncology, because many of the things we do are similar. They overlap.
At least his mom's still there, right? So at least Luke's there.
Thank you for a great talk. I was really intrigued by the toxicity screening you described. Physiologist, trained physiologist, and we study the cardiovascular health outcomes following cancer and chemotherapy treatment. And the connection with that field, cardio-oncology, in the context of geriatrics is highly intriguing. And so I'm thinking about aging is the primary risk factor for overt cardiovascular disease. Aging is a primary risk factor for cancer. And most chemotherapeutics markedly increase cardiovascular disease risk. So I'm curious to get your take on what extent have you thought about, or has the field thought about implementing something at maybe as simple as measuring blood pressure in the context of the toxicity screen at baseline to inform how chemotherapy is delivered?
Yeah, no, that's an excellent question. And I have to say that the collaboration between cardio-oncology and geriatric oncology has been very limited worldwide. And none of the chemotherapy prediction tools, well, yeah, there is a tool called the CRASH tool, which was developed in Moffitt. And that one uses diastolic blood pressure as a risk factor for toxicity. But the most used tool, which is the CARC chemotherapy tool, does not use any cardiovascular factors to grade the potential risk of toxicity. Of course, it's something that we always take into account, particularly when we are using cardiotoxic medications. But yeah, I think that we need to know more both about the cardiovascular risk of chemotherapy and also whether pre-existing cardiovascular conditions increase your risk of having adverse events, which of course they do, but we have not studied that fully, right? Even as a risk factor for cancer, right? All the inflammation related with cardiovascular disease and aging certainly interacts in that sense. But yeah, I think this is fertile ground for doing more research.
We have a question on Zoom. I will read it out. You mentioned other clinicians tend to undervalue geriatrics. Does this affect how geriatrics, let's see here. Oh, sorry, scroll. Oh my goodness. Does this affect how geriatricians embed into interdisciplinary teams? If so, how? Christy, great question. Let me think about that in the context of cancer. So
I think I get the question.
thanks.
So of course it affects, right? When you're working with someone that doesn't want to work with you, that's terrible. Yeah, but I think that the main reason why this happens is because oncologists have been treating older patients without any input from geriatricians for a long time, right? So most oncologists feel that they know how to treat older patients, that they don't need any help in treating older patients because they already know it. They've been doing it forever. And why should they hear advice from others, right? And other people meddling into your disease. And this is sadly quite common. It's becoming less and less common, I have to say. Here in the cancer center, the experience has been amazing, particularly in breast. Everybody's very open to this. They like it. In Mexico, we had people that were impossible to convince. But I think that the way to do this is just being there, holding on. It doesn't matter. It's not personal. And eventually things will change, right? But yeah, I think this happens in geriatrics. This happens a lot, right? With interactions with other specialties. Because other specialties are just not trained to think about this. And you don't know what you don't know. And I think this will change as more and more people get, at least in Mexico, more and more medical school curricular, including geriatrics. 15 years ago, 10% of medical schools in Mexico teach geriatrics, only 10 years ago. And now it's like 80%. So that has been changing. And I'm in the US, I bet that's true too. But yeah, I think that's an issue. And that's why having an oncologist as part of the team is essential. Geriatric oncology clinics that are led or that only have geriatricians can be very successful, but it takes them more time to get into the oncology world.
So I think that all of us in this room really do value the decrease in symptoms for patients and toxicities. Systems tend to care about different things. So they don't tend to care about cost savings to healthcare systems and variably care about patient-related outcomes. But I think it's more about finances and notoriety, essentially. And so I guess, how do you convince big systems to care about things like this?
Well, these patients are very costly for the system, right? Many of these patients have not very good insurance systems, or they're actually, if these patients are hospitalized, in many cases, systems end up losing money, right? So avoiding toxicity, avoiding starting treatments, things like that can actually lead to savings. And there are some cost effectiveness analysis that have been done, particularly in Canada, and they show conflicting results, but of course, it's a completely different healthcare system, right? So I think that we do need to make a business case. And the other thing is that, sadly, geriatrics and the things that we do in geriatric oncology sometimes are not very sexy, right? When you see, oh, we're doing a new immunotherapy and we infuse these cells and people are like, ooh, that's so amazing. And that leads to a two-month advantage in survival, right? But it sounds so sexy that people want to implement it, right? And it's so much easier to just prescribe a medication that costs $1 million, which is certainly not cost effective. Like 60% of the things we do in oncology are not cost effective. But I do think that there are ways in which this can be shown. For example, in Mexico, what has worked a lot is that older adults vote a lot. So the past two governments have made a big commitment at funding things for older patients, because older patients vote for them a lot. So actually catering toward older adults, making things better for older adults can be a very profitable thing for politicians, for systems, etc. And I think we need to exploit that a little bit more and work with the community. The work of patient advocates, etc., is super important, but no patient advocates are older adults. Most patient advocates there are young women, children, adolescents. The face of cancer, breast cancer, the median age, it's 68. And the face of breast cancer is a 40-year-old woman, right? And that is what people think about. When I tell my patients, the main risk factor for what you have, they think it's hereditary. And I say, the main risk factor for what you have is age. All of them are surprised. Like, what? This is something that comes with age? And the general public does not know that. So I think we have to be very mindful of doing those campaigns, educating the general public, policymakers, and decision makers in our hospitals. I know the answer is super complicated.
Yes, I'm so appreciating your themes, and then I'm going to pass to Katie, who may have the same comment, but I appreciate your team-based approach, and I heard you mention community health workers. I wonder if you could describe for us sort of the current state of peer navigators or patient navigators within the cancer center, and how you could envision seeing navigators involved in geriatric oncology.
So there are some navigators within the cancer center in several clinics. The gastrointestinal clinic has navigators. Those navigators mostly have been done or are, their task is to make sure that underserved communities get access to care. So like navigators that speak Spanish or that have access to underserved communities. And it has mostly been focused on getting patients in clinical trials, right? Which is the priority of the cancer center, because that's what gives the cancer center its funding. But of course, this is an essential tool that we could use in geriatric oncology. And many of the interventions, for example, the GAIN trial intervention was mostly a navigation intervention. So the patients had access to a geriatric nurse who did all these interventions, did the referrals, made sure the patients were going to all of this. So yeah, I think that patient navigation is an underexplored strategy in geriatric oncology. And we actually had a talk about this, or a discussion about this at the recent International Society of Geriatric Oncology meeting. And very few people are working on patient navigation for geriatric oncology.
Thank you, Dr. Soto, for this talk. And I actually had a different question, but I so appreciate you acknowledging the importance of community health workers as part of the team, the interprofessional team. My question is, if you were able to move forward with the geriatric oncology clinic, do you have thoughts about the pros and cons of situating that clinic here on this campus versus in the community, like a hotspot for cancer in Colorado, like I think Pueblo may be?
Well, thank you very much for that question. I think the biggest pro of situating it in the cancer center is that all the resources are here, right? And that that could be a good start for creating and building the resources. Very few cancer centers have managed to get out into the community because of this, right? There are some strategies trying to do it through telemedicine. And the other is using community healthcare workers and local providers, which are more generalist, right? Like what has been done with palliative care. Instead of doing specialized care, doing generalist care. So if a patient needs physical therapy, even if it's not a physical therapist that is trained in cancer and in older patients, they can go to a physical therapist in the community that can do some of the interventions, right? So I think that if we were to build a geriatric clinic in the campus, one of the advantages that we have is the great resources here. But of course, due to the nature of the state and the great dispersion of people, the rural population, I think we have an excellent opportunity to create a geriatric oncology model that goes out to these communities in rural areas that are very diverse. Because across the state, we have communities that are so different between them. So it would be an extremely interesting idea to do that and to expand. But I think I would start here and then grow out rather than starting outside and growing in. That's how I see it.
Hi, thanks, Dr. Soto. I was curious to know, what's your vision with regards to how to turn this into research while you're here? We're obviously in an academic medical center, and you're obviously speaking to a group of clinicians, clinical leads, but then also clinician researchers and PhD researchers. So just curious to know if you could plug for yourself sort of what your vision is around that.
So I think that one of the first things that we have to do is to understand what's going on. And this has been my task during the last months in the two things that I'm doing, which is the geriatric part and the global and international health part. And the truth is that there are a lot of people who have interests in this, who want to do research in these things, but the research is scattered, right? Everybody's working in their own thing and people are not together. So I think that the first thing we have to do in order to start a true research collaboration in geriatric oncology is to find all the right partners. And I've been working on doing that from the cancer center side and hope to do it today from the geriatric side. And get everybody on the table, see what everybody's doing, and figure out the opportunities for collaboration. Where I'm actually already working with Abigail Roblecki on some projects, and Liz Kessler has worked with many of you, I know. But again, we have to make sure that this is not an isolated effort, right? But rather a programmatic effort in which we have standing collaborations, standing goals, and that when you are thinking about a project in geriatrics, you think about what is the value of working with oncologists for that particular project, and that when we oncologists or the cancer center is thinking about starting a new program or starting a new research endeavor, that we think about including geriatric assessments and geriatric outcomes into the trials we decide. And that'll take time, but I think that getting everyone together in the same place and figure out what everybody's doing is the start. And I hope that during the next year, we can start a round table and get everybody who's interested in cancer in aging together in one room as a team, like the Cancer Center has done in other things. A great example for it is gastrointestinal malignancies. They have a big screening program in which they work with gastroenterology, with a community side, with international sites, and they've actually created this programmatic thing that does research and that everybody works together. And I envision that for us in the next year, I hope.
Thank you for your talk. I was thinking about how veterans are at higher risk for cancer, and I imagine aging veterans are even higher risk. And with the VA here on campus, do you think working with the VA could accelerate this process? And then I do understand that getting the government involved may have pros and cons, but with this approach, do you think this would be a catalyst to get this up and going?
Oh, well, I think the easy answer is of course, right? The VA is an excellent target for every geriatric intervention you can think of. And in Mexico, I work, the hospital I work in is a government hospital. And actually, when I talked to people in the US about grants and sending us grant money, et cetera, and they didn't understand how it worked, I said, it's like the VA, right? So I am aware of the hurdles and other geriatric oncology clinics. The best example I can think of is in the Ohio State University. They have tried to work with the VA and they have mostly failed to implement things in the VA. But I do think that having the VA so close and many of our providers also working in the VA is an excellent opportunity. And it's one of these things that seem absurd, right? That you have a hospital right next door and it's difficult to work with them. Another hospital that I believe is very important to work with is Denver Health. And I've actually been there a couple of times to visit, and particularly because one of the things that we also have to do is reach out to underserved populations in the area, right? And most of those patients are there in Denver Health. So I think that is something that we need to work on as well. And yeah, building collaborations with other centers here and across the US and abroad, that is something very important as well. There's a lot of work to do, as you can see.
Yes. Thank you so much for an awesome, engaging talk, as well as like this robust discussion. So really grateful for your time.
I'm happy to talk some more. You have my Twitter handle, and if anybody wants to send me an email or reach out to discuss, more than happy to talk with any of you. Chat questions, chat. Click the link below.